Hi, I'm Dr. Richard Visser, and in this podcast, I will take you on a journey through the wilderness of scientific research and experiential knowledge. Together, we will clear a path to optimizing health, well-being, and longevity. I am a former Minister of Health and Sports with a PhD in medical sciences, a published researcher in the fields of obesity, lifestyle medicine, and longevity. I started my career path over 3 decades ago as a doctor of chiropractic. I'm excited to share my methods, know-how, and experience with you. So please join me on the Visser Podcast. Welcome to the Visser Podcast. Today we're going to be discussing two hormonal systems, our thyroid and our sex hormone system, both male and female. The reason is because when starting any program in optimizing our health, in optimizing our nutrition, in trying to, get fit, get to our optimum weight, there could be a couple of obstacles in the road, and they could be hormonal. So we need to do a hormone panel in our blood check, a blood test. And we also need to, if you're of age already, middle ages, or even before, it is advisable to do a hormone panel. So let's start first things first, the thyroid system. So the thyroid system starts off at the hypothalamus in the brain, which then releases thyroid hormone. Thyroid hormone then stimulates the pituitary glands, which are at the bottom of the brain, to release thyroid stimulating hormone, which then signals the thyroid gland, which is right here, right in the throat, to release T3 and T4. So why is it called T3 and T4? Well, T3 has 3 iodines, T4 has 4 iodines respectively. So that's how the name comes. What does T3 and T4 do? What does our thyroid do? Well, it controls our internal temperature. It controls metabolism. Yes, metabolism. How we digest foods, how much we move to fat, how much we use to energy. So you can see here, this is where it gets tricky for the body if it's not functioning correctly. And bowel function. So also an issue, and there's other stuff, but these are the 3 kind of main things that we're looking at. So when we see the release of T3 and T4, T3 is the active thyroid, T4 is inactive, but there's much more T4 being released than T3. I mean, much more. So what happens is that the body converts the T3 with these enzymes called dihydrogenases, D1, D2, to actual T3. Now there's one that's also there, and it's because of our history of being under stress, having been undergone a lot of just famine, in our past, in our history, in our 5 million years that we've been roaming this planet. 99.9% of the time we were hunter-gatherers. We didn't have food all the time. We were struggling, all of us. So our genetics are built for this. And so in that, we see that there is a D3 enzyme, dihydrogenase. Oh man, really? Dihydrogenases. Yeah, my brain's not doing this. So anyway, it's D3. So D3 converts T4 into reverse T3, which does the opposite thing it should do, which is slow everything down. And really, we believe this is in our body because it's one of these things that when our body senses a crisis and senses that we're not going to have food for a long time, or we're not going to have access to energy coming into our body, it needs to shut things down, slow things down, start basically, taking everything it gets in and storing it as fat, so we can survive the drought. And this is due to our history in time. And so it's actually there as a protective mechanism. But in this day and age, it can wreak havoc on our system, because imagine if you got reverse 3 being produced, you're going right into hypothyroidism and getting fat, not being able to get rid of the fat. Your metabolism will be out of whack. Everything will be out of whack. So we really need to look at this closely. We need to get the labs, have our physician look at it, and make sure that our numbers are where they need to be. T3 needs to be well up there. So what else can we say? Well, I think that when we have to look at the interplay, because when we're looking at a lab report, we're looking at thyroid stimulating hormone, T3, T4, usually. And so we have to look at the interplay between thyroid stimulating hormone and T3, T4. So if thyroid stimulating hormone is high, usually means your T3 is going to be low, because it's actually saying, hey, we need to produce more. We need to produce more. That's the message going in. And you're not, for some reason or another, able to produce more. The other thing that can be is that if your thyroid stimulating hormone is low and your T3 is low, then you got to think of, well, maybe this is someone with diabetes or with insulin resistance. So this is some of the interplays that we need to look at. So when we determine that there is a low T3 and we need to treat this, and your doctor needs to treat it, some of the things that we will treat it with will be, and this was one that was used but isn't used that much anymore, Cytomel T3. It was used in the past, but it's just run out of favor. Now what's being used, and I think these two are where it's at, is compounded controlled release T3. And we're looking at 10, 25 to 30 micrograms a day. And then you have the desiccated thyroid formulations. And that's Nature Thyroid or Armor Thyroid. And that's a T4 and T3 fixed amount. Now, some of the physicians don't like this because it's a fixed amount. It's a fixed ratio that you're getting with this medication. Whereas the compounded controlled release is one that you can set off yourself. But it depends on the patient. Some patients do well with controlled release, and some patients do very well with Armor Thyroid. I've seen that myself. So that's where that's at. The half-life of T4 is days. So if you're taking a supplement for T4, don't stress out. If you don't take it a day or two, just keep taking it. With T3, the half-life is much shorter. So that's where you got to keep an eye on that. You gotta basically be on that. So if the TSH, the free T4 and free T3 are not in order, that's the only time we would go and do and order a reverse T3 test. Usually you don't order that. So really the basics of your thyroid, you need to get it checked before starting any program. You need to, because the uphill battle you'll fight if that's out of whack, not good, okay? So let's look at female sex hormones. And to look at this, let's look at the menstrual cycle. Okay, we're gonna take 28 days, which is an average cycle. It's not for everyone. I know there's a lot of differences, but the average is 28. So I'm gonna work with 28 just for, to keep the explanation simple. So day 0, we start, which is the actual menstruation. First sign of blood, menstruation cycle starts, and endometrial lining is starting to shed off. The second phase will be the follicular phase, where we ripen the follicle for ovulation in mid-cycle, driven by follicular stimulating hormone and estrogen. So these two are high at this point. Next comes the luteal phase, which is dominated by the luteinizing hormone and progesterone. Progesterone spikes here, and that happens due to the pituitary gland. Now, If there's no pregnancy at this point, what we're going to see is that progesterone dives. It just free falls. And this is where, and this happens between day 21 and 28, and this is where women get PMS. And with some women, it can be horrible. It can be really bad. And it's real. It's not something, they made up. It's a real thing. So if this does happen, the suggestion is to see your physician and really between days 21 and 28, add some oral progesterone. And that could really help. 50 milligrams usually, 50 grams orally of progesterone could basically, soften that phase immensely. So keep that in the back of your mind. So as a woman gets to perimenopause is before menopause, which, it's depending, could be getting there in their 50s and everything. We want to test the blood. We want to do the blood test. And we want to do the blood test on day 3, 4, or 5 of the menstrual cycle. So right at first blood, day 3, 4, or 5. That's when we want to test. Because we're looking at follicular stimulating hormone and estradiol, okay? We're really looking at what's happening here. So this is where we're going to be able to see inside and say, okay, are we at perimenopause? Are we at menopause? So this is super important. So you got to really know when to get your blood test, because you can get it, at other stages of your cycle, but it's going to be less accurate, and the doctor's really going to have to know what they're doing to be able to see it. So the other thing I want to talk about is that women also, we talk about estradiol, we talk about progesterone, we talk about estrogen, follicular stimulating hormone, but they also have testosterone. And in reality, the testosterone in women stays stable. So it's a stable thing. That's why we don't talk about it, because it doesn't change much. But if we look at the value of how much testosterone compared to estradiol a woman has in their body, testosterone, 10 times the level of estradiol. So when we're looking at hormonal replacement therapy, we're also looking at, optimizing the testosterone levels in there while looking at the rest. Just as a note, most people don't realize that. As estradiol and progesterone go way down, the woman starts producing way high LH and FSH. And this is, way before this stage, we have to be having the talk about hormone replacement therapy. And this is like 1 to 2 years before this starts happening. So really keep an eye on that. Let's talk about it, because as we know, as we've seen before in the episodes before, when we're talking about cardiovascular disease and we're talking about cerebrovascular disease, the biggest killers, period. Women, when they lose estrogen in their bodies, when they go into menopause, all of a sudden become just as high risk almost as men for these two diseases. Before that, much less. Why? They're protected by estrogen. All right? So again, it kind of moves us towards, recommending hormone replacement therapy just for that protection. Another thing is bone density, muscle density, hot flashes, vaginal dryness, and atrophy. Those are some of the other stuff that we're avoiding with this. So yeah, it's and really we're also getting indications that with Alzheimer's disease, dementia, women, as we know, more women get it than men. It's 2 to 3, and they get it late in life. We all get it late in life, but it also has to do with women losing the protection of estrogen and what that does to the vascular system. So yeah, I think we really have to have that talk sooner than later. We get a lot of physicians that refuse to go to hormone replacement therapy when the women are already in menopause. And the belief there is that you may actually push with hormone replacement therapy at that point to more sinister outcomes. There is that school of thought. Not proven, but it's a school of thought. So it is safe to start early, and we need to start early. So let's look at male sex hormones. So we have the hypothalamus producing GnRH. The pituitary releases, of course, LH and FSH to the testes, and they start making testosterone. Most testosterone is bound, and it's bound to two things: SH, BG, and albumin. And a small amount is free testosterone. That's about 1 to 3%. So it's very small of the total testosterone that we're looking at. So this has to do with when we're looking at the labs, okay? So we have two conversions happening with testosterone, and these two conversions happen because we have 5-alpha reductase, which converts a small amount of testosterone to DHT, dihydrotestosterone. And on the other side, we have aromatase, which converts a small amount of testosterone to estrogen. And estrogen we do need. So I know there's a lot of talk out there about aromatase inhibitors, but be very careful with that. I would suggest not to use that. And I also think very, very few people need that. And that's, you're playing with something you don't need to be playing with. So we need the estrogen, okay? Estrogen, really affects the LH, and it inhibits it via the pituitary. So testosterone replacement therapy or hormone replacement therapy, because sometimes we want to also include growth hormone in there. And really what we're doing here, we're not doing a steroid cycle, we're not doing any of that stuff, we're not even touching those numbers, okay? We're doing microdosing here. Basically getting your levels, looking at your blood and getting your hormone levels back to when you were 30. And what this does, is hold on to good bone density, hold on to muscle mass, and strength is what we need. Libido goes back up, so that's good for a relationship. And it has a lot of, positive effects, insulin resistance, etc. So we need to look at the total testosterone, we need to look at the free testosterone, which is calculated by the lab, and the testosterone AR and DHT AR, androgen receptor, inside, and these are inside the nucleus of the cell. So when we look at where we're at with our blood, and we're seeing that, hormone replacement therapy is something we might need at this point, I would suggest to start off with precursors. So talk to your physician about precursors. What are these? These are indirect stimulation, so that your body still keeps making testosterone, but you're stimulating it by HCG, human chorionic gonadotropin, which mimics LH, tells your body to produce more testosterone. It's good. Now, there's also synthetic FSH, but synthetic FSH are really for men that have abused steroids in the past or been too long on replacement and are unable to produce any testosterone in their testicles. Their testicles are basically freaking dead, okay? Nothing's happening there, so we're gonna have to do an exorcism to revive them. FSH comes into play. Most of us will not use it. It's expensive and it's not really good. The other thing that you see coming around is Clomid. It blocks the effects of estrogen in the brain, which is not good for our system. So Clomid, don't really like it. In the end, you're going to have to go on exogenous or bioidentical testosterone. And that's basically, once a week, 125 milligrams is the start out point. Well, we're going to be discussing that with an expert soon. If when you're replacing testosterone, or you're taking too much or a lot of testosterone, and you have an issue with 5-alpha reductase, which means you have too much, you're converting too much of it to DHT, then you might experience some hair loss. So you got to look at that. aromatase. Aromatase is affected by obesity, where your body produces more aromatase, and then in turn will make testosterone go into estradiol more than we would like. So we need to be looking at that too and look out for that. But, you know, we're just looking, with this therapy, we're looking at really getting the symptoms better, looking at bone health, muscle retention, so retaining your muscle strength and your muscle size for as long as possible. And those are the key factors here. And we're microdosing. So I have one message for anyone looking at the episode. For all you young people out there, don't go on steroids. Don't go on peptides. And we're going to talk about peptides because we can also use some peptides to, you know, potentially indirectly, you know, have our bodies produce more growth hormone instead of taking growth hormone directly. It's expensive and it really doesn't, I don't think it functions that well. Testosterone has definite functions, definitely. I mean, you can feel the testosterone, definitely. And again, microdosing. So at microdose level, we're protecting the heart. We're protecting our blood vessels, circulation. It's extremely protective, and we're seeing that. But this has to be done by a physician, someone that knows how to do this, someone that's looking at your labs, monitoring your labs. You're going to be monitored every 6 months or sooner to look at, you know, to make sure that all your levels are on, you know, are on the up and up. And when starting these programs, you know, do the work. Go back to the foundation. You need to be eating right. You need to be exercising right. Okay? And you need to be doing your cardio right. Because if you're just taking this to take this, it's not going to do much. It's not going to do much at all. You need to have your nutrition corrected. You need to have your exercise, a routine in, which includes, you know, strength training, and it includes cardio, zone 2 preferably, because you're maintaining your weight. If you're an athlete already, then you need to see where you're lacking. So a lot of distance people are lacking in strength and muscle hypertrophy. They have to put a little more attention there. You know, the bodybuilders, the muscle guys need to put more attention to the cardio and really look at how to do the cardio best. So we all got our balance to come in, because we know that, you know, VO2 max is king, and we have to basically build more mitochondria and make sure our mitochondria works optimally so that we can have that longevity. And this really gives us the quality of life we're looking for. This ups the quality of life, and it helps you. The idea is that it helps you, that you're not climbing uphill with your diet, climbing uphill with, you know, your exercise routine, with your daily activities, with your love life, with everything. I mean, this settles it. So it helps you. It's that little bit that helps you and makes it great. So yeah, exciting. The next episode, we will switch, and it has to do with this. It all stays in this area. We're going to have to talk about protein and a little bit about diet, because it's one of these elements that if we get wrong, all this stuff is for nothing. Okay, so we're going to have to go through that. And then I promise after that, we'll go to a lighter exercise episode. So stick with it. The information that I'm giving you is vital. The other thing is that we will be interviewing one of the top physicians in Hollywood, California, that does this, that does the hormone replacement therapy for men, males and women. He does actors, he does, you know, famous people. Everyone goes to him, and we're going to be interviewing him. And he's really going to go more in detail on the specifics of what he does, what he checks for, what he does when he's in this thing. For me, for the purpose of this episode, it was really to look at, hey, what do we need to be looking at with our physician? Okay? What are the things that could be, you know, big obstructions in the road to longevity and well-being? And these are some of them. So we need to clear these out. All right. Then the next part is, okay, how do we optimize them? Well, that's when we get the experts in, and we're going to talk to them. So thank you again for joining me. for being on this journey. Subscribe, ring the bell notification, tell some friends about this, and let's keep on this journey of health, well-being, and longevity.